Good afternoon and welcome to Internal Medicine Grand Rounds. There is no commercial support for today's program. The speaker and planners have disclosed no relevant financial relationships with commercial interests. If you have a question for our presenter, please hold until the Q&A segment at the end of the talk. And if you're attending virtually and have a question, please enter it into the Q&A section. Also, a link to the event survey will be shared at the end of the program. It is my pleasure to introduce our guest speaker, Dr. Henry Colorado. He is currently a third-year internal medicine resident, originally from Columbia, South America, and calls Anderson, South Carolina home. He received his medical degree from the Medical University of South Carolina in Charleston. Dr. Colorado will be completing a chief resident year at East Carolina University in Greenville, North Carolina, and then has plans to pursue a fellowship in gastroenterology. Please join me in welcoming Dr. Colorado.
Hey, good afternoon, everyone. Thank you for joining me. My Grand Rounds is going to be about the advancements in gastroenterology and what I believe a general internist should know, made by myself. Disclosures, I don't have any. Objectives, they're listed here. I'm not going to list all of them and go through them, but we're going to be going through quite a few things. Four kind of big categories that I would like to say. Three of them definitely pertinent to an internist. The last one is more because I was interested in it and figured why not throw it in here. So we'll start out by presenting a patient at the start of each kind of topic. And I'll just read it out to you guys. So we're starting out with Mr. Liver. He's a 55-year-old male, past medical history of obesity, type 2 diabetes, osteoarthritis, hypertension, presents to clinic to establish care with you after a health fair that he recently went to, showed that he had elevations in his AST and ALT. Pretty, typical patient that we'd definitely see in the resident clinic. He recalls that previous imaging remarked that he had fatty liver. He has questions on what this all could mean and what further workup needs to happen. So we'll start by talking about MASH. And I'm not talking about the old TV show MASH, but I'm talking about what the AASLD has now redefined and come up with new naming for metabolic dysfunction-associated steatohepatitis, previously known as NASH. The naming has also changed for a few other things, and the reason for this is because the AASLD wants us to know and wants us to understand that this is not, that this is a metabolic process. This is not solely just fat deposition, but they want us to understand that this is a metabolic problem. So we have MASH. We also have a few other things. Previously, what was known as NAFLD is now known as metabolic dysfunction-associated steatic liver disease, or MASLD. You'll see that later in the presentation, still with the old naming. And then for those who are curious, there's also new naming for those who have concomitant metabolic dysfunction and who also consume excess alcohol. This is known as MET-ALD. That I won't talk about in this presentation, but just so you guys are aware. So MASH is 5% or greater hepatic steatosis with hepatocellular damage and inflammation seen in the liver. That is, when you have that degree of inflammation and you see that under biopsy, you can, without a shadow of a doubt, say that somebody has MASH present. You have inflammation at play in these patients that can then progress to fibrosis. The stages of fibrosis, and we'll talk about this later on with a different picture, stages F3 and F4 are associated with death. So this is a picture just depicting how exactly this whole process happens. As you can see, there's more than just a few things at play here. I want to point out that at the top of our picture, we have the gut microbiome, because that is important. We also have peripheral adipose tissue, and then we have things within the hepatocyte itself, such as the mitochondria, and then the steatosis that happens within. So the presence of MASH is determined by factors that govern the supply and deposition of fatty acids, diacylglycerols, ceramides, cholesterol, phospholipids, and essentially energy oversupply and limited energy oversupply and what the hepatocyte sees via blood supply will cause de novo lipogenesis, which we see in the box in red right over here. So DNL. We also have reactive oxygen stress that occurs within the mitochondria when all of this occurs, and then we have steatosis at play as well. The purpose of this slide is, again, just to reiterate that this is a whole metabolic dysfunction that occurs within patients. There is also genetic factors at play that have been identified. So it's not just as simple as fat depositing into the liver. There's a lot of things at play. So who all is at risk? People who have type 2 diabetes, people who are obese, and then people who also have metabolic risk factors such as hypertension and hyperlipidemia. That's not to say that people who are not obese are not at risk. I want to make that clear. You can have people who are non-obese and still have steatohepatitis at play. So where exactly does the internist play a role in identifying this process? So the AASLD has kind of made this algorithm here for us to know where our role is. For step one, we identify patients who are at risk, as I just mentioned on my previous slide. Step two, we want to obviously take a history, get some basic labs, and then we want to use this non-invasive score that they have developed called the FIB-4 score. I'm sure you guys have used it, but essentially the FIB-4 score, it takes into account 4 different things: your age, your AST, your ALT, and your platelet count, as a sort of screening modality to see what underlying fibrosis is at play. So this score is validated and ideally should only be used between the ages of 35 to 64, because that's what it was invented for. However, I've seen some people use it outside of that range. People who have an elevated FIB-4 score between 1.3 to 2.67 are considered indeterminate risk, and above 2.67 are high risk and should immediately be referred to a hepatologist. So let's talk about the indeterminate risk patients. These patients should then have further workup to evaluate the liver stiffness. This is kind of seeing what underlying cirrhosis is at play. We have a few imaging modalities for this. We have MRI, and then we also have the FibroScan that different groups use as well. Knowing this will kind of then further stratify a patient into low risk, indeterminate risk, or high risk. Again, this is the old naming, the NAFLD spectrum, which again now is MASLD. So you have a normal liver that then will have fat deposition, i.e. your MASH, after it's gotten more than 5%. And then after a while, which again, we cannot predict who will or who won't progress to fibrosis and at what rate, we'll then go into the 4th and 5th stages over here that we see, which is MASH with fibrosis and then cirrhosis. And as we know, patients with cirrhosis have elevated risk of hepatocellular carcinoma. And then here, I want to point out at the bottom of the slide, shows us our F1, F2, F3, and F4 classifications. Again, this is all done via biopsy. So how do we treat it? Well, let's talk about what AASLD was talking guideline-wise in May of 2023. No FDA-approved medications were at play. A lot of it was based on weight loss recommendations, so we would tell our patients to lose weight, as we knew that that would benefit them. Pioglitazone, GLP-1s, vitamin E, these are all things that were being discussed, and then some other RCTs, which mentioned pioglitazone and vitamin E in a trial called the PIVENS trial, showed some benefit and some resolution in MASH in patients. However, nothing FDA-wise had come about these 2 players, pioglitazone and vitamin E. At the end of the day, all of these were suggested treatments, but none of them had any benefit on the fibrosis stage for patients. That's where we were in 2023. in the New England Journal of Medicine, February 2024, we have a phase 3 randomized controlled trial of resmetirom in patients, again, old naming, with MASH and liver fibrosis. This came out in February of 2024, so not that long ago. Let's kind of go through the methods of this. So you've got 1,050 patients. 966 of these patients had between F1 to F3 fibrosis. I want to point out they excluded those with F4 with just full-on cirrhosis. They were then randomized into 3 different groups: placebo, 80 milligrams, and 100 milligram dose of resmetirom. They were followed for about 52 weeks with a liver biopsy obtained at the end of the trial. So they had one before, and they had one at the end of the trial after 52 weeks of being followed. This table kind of breaks it down so you guys can see that they tried to place each third of these patients and stratify them accordingly to where you have pretty homogeneous sample on each size, the resmetirom 80, 100, and the placebo group. So this is the results table from this study. We'll go through it. So what we see is that, you know, with the MASH resolution with no worsening of fibrosis, it showed that it was superior to placebo. So you had resolution of your MASH, and then you also had fibrosis improvement by 1 stage. So if you were in F3, you would go back to an F2. If you're in an F1, you wouldn't have any degree of fibrosis. Other kind of things that they were looking at in this study was looking at changes in your LDL cholesterol as well. So they made note of that. You had LDL reduction with resmetirom as opposed to placebo, and there were some secondary endpoints as well, looking at AST, ALT, and different lipoproteins that also demonstrated benefit. But this was a huge, groundbreaking trial for those with MASH, because before this we didn't have anything that would reverse any sort of fibrosis in these patients. A few more conclusions and limitations. So the resmetirom 80 and 100 are both effective in reducing fibrosis and NAFLD activity. I know I need to change that. It also showed an adequate safety profile. Most of these patients just had nausea or abdominal pain, things of that nature when taking this medication. And then this study is also limited by no long-term clinical outcomes data. That just means that these patients were only followed for 52 weeks. Even though we have the biopsy at the end showing reversal of their fibrosis stage, we don't know, 52 weeks after the study, 2 years, 3 years, 5 years down the line, what exactly happens with these patients. I'm sure that they'll continue to follow them and we'll have more information down the line, but as of right now, this is a huge limitation for the study. So how exactly does this new medication work, this resmetirom? So resmetirom is a thyroid-like medication. It mimics T3, as we can see here. So T4 is converted into T3 in the liver. T3 will then go into the nucleus of the cell and bind to THR-beta and RXR, which causes the cell to then make CPT1 and SREBF1. CPT1 is responsible for fatty acid oxidation within the mitochondria, and then the SREBF1 is responsible for de novo lipogenesis within the liver. So resmetirom mimics, T3 in this sense, in that it goes into the cell and does the exact same thing. However, it blocks these transcription factors right here from ever making CPT1 and SREBF1. And that's essentially how it works. So we think that there's a degree of thyroid issues that also lead to this, to the MASH in patients. So moving on, the AASLD then came out with a practice update in October of 2024 after the NASH Maestro trial, which we just read about, was published. And this is what they recommend. So they recommend that we use resmetirom in our patients who have imaging showing a degree of fibrosis within the liver, as well as liver pathology or liver histology consistent with an F2 or F3 staging. So this is right before you get to cirrhosis. It's not recommended for people who have any excess alcohol use or have active thyroid issues. So again, this is where the history in talking with our patients comes in handy, and also checking for TSH and T4 before starting patients on this. This medication will likely just be reserved for hepatologists, but I think it's important for us to know. So here's one of our questions. Question 1, we've got a 55-year-old male with past medical history of obesity, type 2 diabetes, osteoarthritis, hypertension, presents to clinic after going to a health fair with AST and ALT being elevated. He says that he had previously been told that he had fatty liver on imaging. His FIB4 score is elevated at 2. What is the best next step in management? Does anybody want to take a...
E as in elephant? The group is going to go with E as in elephant.
Good job. So yeah, both C and D, I don't know if you can see that little bit of bolding here, but yeah, both C and D, you want to recommend lifestyle modifications and then refer to a hepatologist. This is based on the algorithm that the AASLD had for us. All right, so that's it for that. Let's go on to our new patient that comes in to see you, Mr. GERD. 33-year-old male, past medical history of hypertension and uncontrolled GERD, presents to clinic after having failed therapy with multiple PPIs. You've even got them on BID dosing and has failed H2 blocker therapy as well. He's seeking further options for controls of his symptoms. He reports an EGD a month ago, which demonstrated what he calls erosions within the esophagus. So this brings me to erosive esophagitis. So erosive esophagitis is diagnosed via EGD. As we can see here on the left of the screen, my left, your right, you've got grade A, grade B, grade C, and grade D classifications of esophagitis. If you guys ever were curious what those terms meant, you can see it here. It's all based on how much mucosal break is present, as well as how much they can see circumferentially whenever they're doing the EGD. This occurs subsequently after a patient has GERD that's uncontrolled. About 21% of patients with GERD in the U.S. will end up having erosive esophagitis, somewhere around that range. You also have your current treatment just being PPIs, and even going to BID dosing for these to help patients with this. That's really all we have as the mainstay of therapy. So then we've got Vonoprazan. What is Vonoprazan? It's considered a novel, quote unquote, potassium competitive acid blocker. I say quote unquote novel because it's already been used in Japan since 2014 with multiple indications in Japan. They use it for a number of things such as peptic ulcer disease, they use it for GERD, they use it for erosive esophagitis, and things of that nature. So it's been in the market, just not in the US for a while. Vonoprazan is interesting. So PPIs work exclusively on active proton pumps within the stomach. Vonoprazan has shown in animal studies that it works on both active and inactive proton pumps. The duration of the medication within the system is somewhere around 7 to 8 hours. PPIs are typically somewhere around 1 to 2 hours, which is why our recommendation is always, 30 minutes before you eat, take the medication, or sometimes needing to go to BID dosing. So this slide right here is actually taken straight from the website from Vonoprazan, the manufacturer Voquenza. Here we can see our proton pump in blue. That's at the secretory canaliculus. We have our PCAB out here in the stomach, and what it does is it binds here at the potassium binding site and blocks the hydrogen ions from going into the stomach. So that's simply how these medications work. So the AGA published this back in 2023. It's a head-to-head trial, which I thought was pretty cool. In medicine, we're always taught that These drug makers never want to do head-to-head trials because you never know what's going to happen. You may show that that your medication is inferior to what's already on the market. But this one is Vonoprazan versus lansoprazole in the healing and maintenance of erosive esophagitis. It was a randomized trial. I know this slide is busy. I'll kind of take y'all through it. You had 4,000 patients who were screened, 1,000 patients who were then randomized. These patients then, they screened, they saw that they had a degree of erosive esophagitis. 500 of them got what is known as the healing dose of the Vonoprazan, and then the other 500 got the healing dose for lansoprazole, which was at 30 milligrams. They did this for 8 weeks, and then at the end of the 8 weeks, they did analysis on all these patients. After that, they then randomized these patients again. About 100 of them dropped out, so we were left with 900. So of these 900, they then split them up into 3 different groups. One group, and this is the maintenance phase, one group is to get lansoprazole at 15 milligrams, another group is to get Vonoprazan at 10 milligrams, and then one more group to get Vonoprazan at 20 milligrams. They were followed, I believe, for another 24 weeks to see, what ended up happening after that time period. So it's a little bit of also a different study process. We typically see patients followed from start to finish on the same therapy, but this one has like 2 different randomization periods. So here's one of the tables. We have the primary endpoints, and this is after the healing phase. Remember, the healing phase is just the 8 weeks on the high dose of vonoprazan and lansoprazole. And what we see here is that we had, by week 8, we had a difference of 8.3 in percentage of people who had been healed from erosive esophagitis at 93% with the vonoprazan and 84% with the lansoprazole. They also took a look at heartburn-free days. The difference was not that significant, 66.8 to 64.1 with only a difference of 2.7. And then the healing at week 2 in grades C and D of LA grade C and D of esophagitis was 70% versus 52%. So LA C and D, as you recall on the last slide, was the most severe of erosive esophagitis. Yeah, those are kind of the biggest things that we take away from the healing phase of this trial. Now, if you look here, this is after the maintenance phase. Again, they were randomized again, and then they were given either one of 3 medications, vonoprazan 20, 10, or 15. The healing was maintained best at vonoprazan 20. If you see here at the top left, 80% had healing maintained. Vonoprazan 10 was a little bit different, but regardless, these 2 showed more benefit than the lansoprazole 15. And then again, at our worst, our LA grade C and D, we had 77% healing and 74% healing compared to 61% of the lansoprazole. And again, they took a look at heartburn-free days. Across the board, it was about the same. And then as general internists, we also know that PPIs are not good for you in the long term. So they made a mention of things like C. diff and bone fractures in all of these groups. And as far as bone fractures were concerned, the vonoprazan did have more fractures altogether than just the lansoprazole alone, but percentage-wise, it was not big, 1% or less at max had a bone fracture, and then nobody had C. diff. And then some patients did get COVID. This was during the COVID years. So conclusion, vonoprazan demonstrated efficacy in treatment and maintenance of erosive esophagitis, especially in your grade C and D. No difference was seen in GERD symptoms. No significant difference in rates of C. diff or bone fractures were seen. And a future study should include BID dosing of lansoprazole because they were sneaky. If you look at the maintenance phase, they only included single-day dosing of lansoprazole where they could have done BID dosing. I just wanted to point that out. So this medication, in my opinion, shows very good efficacy for these things. What other uses are there for Vonoprazan? Well, one of them, for my ICU folks, one of them has been shown in duodenal ulcers or peptic ulcer disease to show very good rates of keeping ulcers, even high-risk rebleeding ulcers, from bleeding again. And then H. pylori is another one that I'll go into now. So H. pylori, as we know, leading cause of peptic ulcer disease and gastric adenocarcinomas and GALT, increasing rates of therapy failure. That's why we have salvage therapy now. That's why we have to use quadruple therapy, which quadruple therapy, for those of you that may not know, includes bismuth in it, a PPI, a tetracycline, and metronidazole. There are thoughts as to why we're having increasing rates of therapy failure. One of them is just having more resistance to clarithromycin. Another reason is just there's a lot of pills and it's hard to take all of them during the 2-week span that you need to be on them. So we have H. pylori being looked at by another study, which is the Vonoprazan triple therapy and dual therapy for H. pylori infections in the US and Europe. This one was also a head-to-head trial. I'm not going to get too into the weeds of this trial, but this one shows Vonoprazan dual and then triple therapy compared to lansoprazole. Looking at these graphs, they're trying to kind of show you that in terms of treatment and eradication, the Vonoprazan did better than lansoprazole at triple therapy. The reason I'm not getting too into the weeds about this study is because I personally did not like that they did a head-to-head with what guidelines are not recommending as first-line therapy. Right now, it's quadruple therapy. So I just wanted to show this. Best practice advice. So this comes straight from the AGA. Best practice advice on how we should use these novel PCABs. Based on cost of the medication, they may not be the first line or most cost-effective. However, you can consider them for people who have non-erosive esophagitis and who have failed BID therapy with PPIs, or you should even use it for the most severe cases of esophagitis. The AGA is actually recommending that we should use the Vonoprazan triple therapy for eradication of H. pylori, and we should not be using these as first-line therapy for prophylaxis or treatment of peptic ulcer disease. Question number 2. So a 33-year-old male, past medical history of hypertension, GERD, failed multiple PPIs at BID dosing. You review his EGD, he's got LA class D esophagitis. What is the best next step in management? We've got referral to Nissen, we've got B, starting patient on Vonoprazan, we have C, starting patient on famotidine, and then we have D, starting patient on TID dosing of lansoprazole. What do you guys think?
We are going to go with B as in boy.
Good job. Yeah, B as in boy. Starting patient on Vonoprazan. All right, we got Miss Obese. This is our third topic. We got a 45-year-old female with past medical history of obesity, hypertension, and osteoarthritis. She's wanting to discuss weight loss modalities. She's currently at a BMI of 40. She's lost a total of 15 pounds after 3 months of lifestyle modifications. She's noticed her weight loss is starting to slow down and wants to discuss further options for weight loss. So what are our current modalities for weight loss? One, we've got bariatric surgery, we've got GLP-1s, we've got newer oral medications such as Contrave, which is bupropion and naltrexone, and we've got Qsymia, which is phentermine and topiramate. Just for you guys' benefit, you know, I made an effort to look up what is the percentage of weight loss that we can expect with all of these medications. So for our GLP-1s, as we know, tirzepatide and semaglutide, we can expect somewhere around 20% weight loss with tirzepatide and 15% with semaglutide. For phentermine and topiramate, somewhere around 9.2%, and with naltrexone, bupropion, it's 5.6%. Bariatric surgery offers the most amount of weight loss with somewhere between 25 to 30%. So come in and enter endoscopic sleeve gastroplasty. I don't know if you guys have heard of this, but we'll take a video, or we'll watch a video to see exactly what this is. Oh, there we go.
This animation depicts the endoscopic sleeve gastroplasty procedure. The endoscope is inserted through the mouth into the stomach. The aim of this procedure is to reduce the volume of the stomach by approximately 70%, similar to a surgical sleeve gastrectomy. The front and back walls of the stomach are marked to help guide placement of the sutures. Then, the endoscopic suturing system is attached to the endoscope and used to take full-thickness bites through the wall of the stomach. We perform a running suture pattern that connects the front and back walls of the stomach. Then, the sutures are tightened, bringing the walls together. This pattern is repeated along the stomach to not only reduce the volume, but also the length of the stomach.
So that is endoscopic suture gastroplasty. Very novel thing. It offers organ sparing for those that want it. Endoscopic sleeve gastroplasty was then looked at by the Lancet in what's known as the MERIT trial. Looking at the MERIT trial, we had adults between the ages of 21 to 65 with BMIs of 30 to 40 with a history of failure with non-surgical weight loss. 209 patients were randomly assigned. They did a weird thing in this study too. They did 1 to 3. 1 to 3 means that for every one patient in the endoscopic gastroplasty group, there were 3 patients in the control group. Double blinding was not possible in this study because to blind patients, you'd have to do a sham procedure, and they felt like that was unsafe to do. So they were not blinded in that respect. Okay, so a little bit of a busy slide. I kind of went through this already on how they were assigned. Once they were assigned, they were followed for a total of 52 weeks. And then at the end of 52 weeks, they analyzed data to see kind of where patients were at. What's interesting about this trial is then they had a second part to this where they continued to follow the original people who underwent endoscopic gastroplasty for another 52 weeks, but also offered the option to retighten their gastroplasty based on procedures that they had that the endoscopist decided on. Only a few of them needed retightening, and then they were followed for 104 weeks. That was the procedure arm of the group. Then they offered this procedure to the control arm of the group. They said, okay, we followed you guys for 52 weeks. You guys had done intense or lifestyle modifications for the course of 52 weeks. They offered that procedure to them. About 6 of them declined, and 8 of them were not eligible to undergo this procedure, but then they were followed for 52 weeks. I hope that made sense. So we have our first graph here that shows us the amount of weight loss that the patients went through. The dark blue right here indicates the primary endoscopic gastroplasty group. The red over here is the control group, or just the lifestyle modification group. So as you can see, we had a significant amount of weight loss over the course of the first 52 weeks compared to this group here. After that, they followed this group for another 52 weeks, and the amount of weight loss was about consistent as it was during the first year of the study. And then you see this arm right here, who was offered the endoscopic procedure, then had about the same amount of weight loss. So I just want to point out the difference between these two graphs. So this graph and this graph are different. They're different because on the left, they show us a mean percentage of excess weight loss. So they're quoting excess weight loss at around 25%. But if you look at total body weight, it's going to be somewhere around 10 to 12%. I just wanted to point that out. As far as adverse events, like anything that's a procedure, we want to be worried about adverse events. Mainly what they saw was abdominal pain, nausea, and vomiting. This is how they decided to break it down and show it. But as we can see here, the longer you went after the procedure, the more and more that these symptoms went away, to where at 52 weeks, less than 10% of these events were being reported. So discussion, you have somewhere around 12.5% overall weight loss. The study will tell you it's 25% of overweight weight loss or excess weight loss. Most adverse events, as I mentioned, disappear with time. No patient in the study, so 102 weeks of over 100 of these patients did not require reversal at all, which is possible. GERD was actually not a significant side effect. So in bariatric surgery, that is something that patients complain about a lot. Patients with lifestyle modifications did not do any better than those who didn't have lifestyle modifications prior to the procedure. And for those who could not be on a GLP-1 for whatever reason and would prefer an organ-sparing procedure, this is a reasonable alternative. I apologize, but the end of this one is cut a little bit. But it's our same patient, our 45-year-old female with past medical history of obesity, hypertension, however, has a history of suicidal ideation and osteoarthritis, presents to clinic wanting to discuss weight loss modalities. Her BMI is 35. She's lost 15 pounds. She's noticed that her weight loss is starting to slow down. She expresses that she doesn't want bariatric surgery, and she also has a family history of MEN2A. What is the best next step? We've got A, which is giving the patient Contrave, B, which is starting low-dose semaglutide, C is referring the patient to a bariatric surgeon for gastric bypass, or D, referring to a bariatric surgeon for ESG. What do you guys think?
What do we think? D as in dog.
Yeah, good job. So because this patient has suicidal ideation, there's a black box warning for Contrave that we wouldn't want to start them on for those who have SI. Because of the MEN2A, we wouldn't want to do semaglutide, and because they're already telling you they don't want bariatric surgery, we wouldn't do that. All right, last thing to talk about, IBD. This is the one that I was interested in. I don't have a question for this one, but IBD, as we know, is a mix of both Crohn's colitis and ulcerative colitis. It's a disease that's very difficult for patients to manage, and sometimes patients will feel fine but still have underlying mucosal inflammation. So IBD has been a field that has drastically changed in the course of these last 10 to 15 years with new inventions and medications. In the past, we just had a handful of medications that we had for patients, and a lot of these patients would also get total colectomies in the hope that their IBD would get changed or cured. So nowadays, the landscape is different. Medical management is fantastic for these patients. However, we're still in this field of trying to determine how do we know that the medical management that we have these patients on is effective. So we use things like biomarkers as well as our clinical assessment of patients to determine whether or not the new medications we've started them on are actually working. However, there are shortcomings in these things. You could have mucosal inflammation still present with normal biomarkers and normal symptoms. Right now, endoscopy is, by all intents and purposes, the gold standard to know whether or not mucosal inflammation is present. However, I don't think any of us have been through a colonoscopy, but we know that, and we tell patients that the prep for colonoscopy can be pretty rough on people. There's also the discomfort of having to go through a procedure. Mind you, IBD patients have to go through more colonoscopies than your average population for this very reason, to one, identify whether treatment is working, and two, they're at higher risk for colon cancer. So we've got intestinal ultrasound that has recently come up and is starting to garner more and more favorability with our IBD specialist as a way to kind of identify and see if there's mucosal inflammation present. So here in pictures A and B, we've got two ultrasounds present. One is for a patient on the left, which is patient A, who has no mucosal inflammation present, and then over here on side B, who does have mucosal inflammation present. What we're seeing here, and we can't really see it, is with this capital A, they're measuring the mucosal line that is not significantly increased here, whereas over here you can start to see that it is. And then this is also just another picture of a healthy patient or a patient without any mucosal inflammation on your left, and then one who has active inflammation on the right. And here, a trained ultrasonographer can see the cecum, can see the IC, the TI, and things of that nature. And then they can also identify, where these sites of inflammation are at. Studies are showing that intestinal ultrasound is a viable imaging modality to assess the response of medical therapy in those with IBD. You have other imaging modalities such as MRI, biomarkers, pill capsule endoscopy, CTs as well. But ultrasound just offers the ability of something without radiation exposure, something that's cheaper, and something that is going to be definitely more comfortable for the patient. However, there are limitations to this. Only a few trained physicians have the ability to do this, and it's starting to garner, like I said, more and more attention by our IBD specialists. So it's going to be something that will be limited to IBD tertiary centers and things of that nature. So this is the end of my talk. How will all of these things impact our future? This is my personal opinion. So going back to our first thing, the resmetirom for MASH, what I see is we're going to end up having concomitant GLP-1 therapy with resmetirom for those with MASH. The AASLD is already reflecting that in their sort of recommendations, but they're waiting on GLP-1 studies to come out. Vonoprazan, I think, is going to become a more popular alternative for GERD. It's already FDA approved for erosive esophagitis and FDA approved for H. pylori, but I think it will just garner more and more popularity. Right now, we're limited by insurance coverage for prescribing this medication. And then even more in the future, I think this medication may have a role in peptic ulcers. Just the studies that I've seen on it have demonstrated that it's pretty effective when compared to pantoprazole for the peptic ulcers. And then ESG, I think it'll become a more well-known alternative to bariatric surgery as more surgeons and gastroenterologists become familiar with the procedure. And then last, I think tertiary IBD homes will likely use biomarkers and intestinal ultrasound to routinely assess for treatment response in their IBD patients. All right, what questions do you all have for me?
Thank you, Dr. Colorado. If you're viewing online and have a question, please enter it in the Q&A section, and we'll ask that for you. In the room, any questions or comments?
Thank you, Dr. Colorado. I'm not sure if you mentioned, but how new is this ESG procedure? That's my first question.
Yeah, ESG, let's go back and see if I quote the study. This publication in Lancet is from 2022, and I think the FDA approved it within this time as well. So relatively new.
So just a few years.
Say that again?
So just a few years, basically.
Just a few years. Right now, within our health system, the only people I've seen do it are people, are surgeons within Longstreet Clinic. Currently, our GI group isn't doing this procedure right now.
Okay. Well, in your review, and you probably haven't come across it because it's new, but did they talk about vitamin deficiencies in ESG compared to bariatric surgery, especially since you're not cutting out gastric tissue, you still have it?
Yeah, they didn't straight up mention that, but I don't think that you're going to see the same amount of vitamin deficiencies that you do in things like gastric bypass, or especially the Roux-en-Y's, where you're actually changing where all the CBD is draining to in terms of the process of food. So I don't think that's as much of a concern with this procedure.
Okay.
Great presentation, Dr. Colorado. I have one more question on this procedure. What were the complications, if you read up on any, with the specific procedure?
Well, we have our adverse events here. Complications for this one are going to be essentially treatment failure, where for whatever reason you're not able to complete the procedure. But apart from that, I didn't see anything severe like any damage to arteries or anything like that. I didn't see anything as far as truly severe things. These patients were followed for 104 weeks, and there was no mention of anything from this procedure that led to demise or anything like that. I think it just, because it's not an open procedure, and you're not actively removing organs from patients or parts of organs or doing that, you're going to have less complications than you would with bariatric surgery.
Thank you, Dr. Colorado.
Yeah, thank you guys.